Thank you to ERG and everyone. Happy Asian American Heritage Month. I think that the federal Heritage Months and the recognition that different communities need support and um, uh, providing a time of insight and community is very important. And I'm so delighted that we have been invited to share the next half an hour, 45 minutes, really thinking together about what Asian health is in America and really how we got here and what we can do about moving forward to improving the health of our communities. So I'm Dr. Srinivasan. I'm a clinical professor here at Stanford and one of the associate directors for our Stanford Center for Asian Health Research and Education. I also direct two research programs around Asian health, one for undergraduate, early graduate students called Stanford CARE Scholars. And if you guys have kids who are in that age group, please encourage them to apply. It's a data science program. And the second one is a team science fellowship that supports the CARE Scholars program for PhD level and master's levels people. Do a lot of other stuff as well in education and the humanities, but that's not why we're here today. So I wonder how many of you know how many people in the world are Asian. It's actually the majority of the globe. So 60% of people in the world are Asian. About over 7% of people in the United States are Asian. But in the Bay Area where we're all residing, it's about 30%. And in fact, depending on the county that you're in, it could be 4 in 10. Okay. It's a very, very large number of people. But you might be surprised to learn that despite our very large presence in the community and our contributions economically and otherwise to society, we have only 0.17% of NIH funding. So dramatically less than our population size and societal contributions. So you might ask, why is that? And while we are the largest growing racial group in the United States, um, uh, we're actually not well represented in a lot of parts of government and a lot of parts of healthcare, and we'll get into that a little bit later. Now, of the Asians in America, about 80% of them are made up of the fairly large groups of Chinese, Asian Indian, Vietnamese, Korean, Japanese, and Filipino, with a long tail of about 16% of people who are from Indonesia, Nepal, Burma, Taiwan. And in fact, of the new immigrants to the United States, about 1 in 3 of them are Asian, others coming from Central America, from Europe, from Canada, and other places. Now, this sounds great. We're part of the United States, and there's a large percentage of us, maybe 1 in 12 to 14. And so you might ask, well, how about our health? How is it Asian health? Well, you'll be surprised to learn that Asian health really varies. And when we look at Asians in aggregate, the health of the population seems like it's actually not too bad. But when we begin to disaggregate by the specific Asian ethnic groups, we actually find massive disparities. And part of that stems from the fact that we're not represented in clinical trials. So while Asians are 60% of the global population, really only 11% participation in clinical trials. And then if you look at pharmacogenomic research and genetic research, it's actually even less. Now, this is extremely important because now Asian health decisions are being made using non-Asian data. And that leads to several things, right? So first of all, uh, Asians are looked at in aggregate. They are omitted massively from studies, and Stanford and other groups are making efforts to correct that. But then you end up extrapolating what works in one group to what works in another group. And some of the times that's okay. But actually, for Asians and for many other ethnic groups, we need to have a finer look so that we understand the social, cultural, lifestyle, and genetics that drive health outcomes. Okay. So The social determinants of health vary quite a bit amongst Asian subgroups. You may be surprised to learn that whereas overall it looks like Asians have a fairly high representation in higher income levels, if you start looking at some of the people from Southeast Asia, the rates of poverty are actually quite high in the communities. Immigration trends I touched upon. And why people come into the country, how they come in, and other sociodemographic factors that really drive health outcomes. And so data disaggregation is very important, and without that our outcomes are masked. So part of the problem is that, and part of the reason funding has not been directed towards Asian Americans, in addition to lack of community voice, is that we've been held back by something called the model minority myth, which is where Asians are hardworking, easy to collaborate with group with amazing outcomes, both from education and from socioeconomic status. And that's just simply not true. It's a very harmful stereotype that's used to divide us and, in fact, divide ethnic groups amongst each other, pointing out that one group is better than another in one way or the other. And simply, this is not true, right? So once we begin to disaggregate, we can actually start to understand differences based on being new Americans, on culture, with mental health, decision making, nutrition, and lifestyle, and disease specific risks. The picture on the left is actually my parents when they came from India to Canada, where I was born, and then we immigrated to the States when I was about 3 or 4 years old, and the hopes that they had for their family's future. As I was growing up in the Midwest, there was quite a lot of discrimination against Asians. And I don't know about you and your families, but there was a lot of racism and a lot of hate, along with, welcoming and community. So after my medicine residency and when I was doing my research fellowship, and I was chatting with people about things happening in the Asian communities and some of my personal experiences and the experiences of others, people would say things like, "Oh, that's nice, but the African Americans have this issue and the Hispanic Americans have this issue." And I said, "Well, all of these issues are fairly important. We should study them." But at the time when I was a young health services researcher, there was no vehicle to do so. And I think you'll find, as you're going to see from some of the research, how much things have evolved and gotten better in terms of us understanding health risks over the past 20 years or so. I was also struck as I was going through my training and over the past years about issues about how people make decisions in Asian communities versus others in terms of group decision making or ceding decision making to a family member or collaborating with them very differently, and the input that we have as we are thinking about a culture, generationality, multi-generationality, living together and commonality. Um, I can give you multiple examples of health specific risks that really made me want to focus in this area. For instance, I personally had family members who had heart attacks, young men and women in their 30s, uh, and we'll go through some of the data on a cardiovascular disease. Or I'm sure this may have happened to some of your family members as well. People being placed on a medication, and that's a standard medication that's well tolerated, and having a severe drug reaction, either because for a clotting medication, a medication to prevent clots after a heart attack, they either started to clot too much or they were bleeding quite a bit, or as with some of the statin medications, the medication dose was incorrect because they were overproducers or underutilizers of the medication based on the way they were metabolizing it. So genetics, exposure, all of these things play into our community health. So, if you take a look across leading causes of death across Asian subgroups, the top two are fairly interchangeable, and this is the same thing with non-Hispanic whites as you look at heart disease and cancers. But then after that, you start to see differences in rates of death from Alzheimer's, from pneumonia, from suicide. So, suicide, for instance, overall for Asians is the seventh or eighth leading cause of death. Whereas for overall non-Hispanic whites and other groups in the States, it's between 11 to 13. Okay. And so this issue of health disparities is very important as we look across our very diverse communities. And largely, these can be broken down into categories like, cancers, and tobacco use is kind of a marker for other lifestyle issues, mental health, cardiometabolic disorders, sleep, and pharmacogenomics, which I briefly touched upon. So if you take a look at it, the aggregate, cardiovascular disease, it looks like, compared to non-Hispanic whites, the majority population, it looks like Asians are doing pretty well. But once you begin to disaggregate them across groups, what you'll find is that Asian Indians and Filipinos and Vietnamese have much higher rates of cardiometabolic disease of coronary artery disease than other groups. In fact, almost twice as much, and it presents earlier, and the prevalence is increasing. Okay. So this is driven by quite a few factors, from high LDL, which is the bad cholesterol that you don't want to have, and also persistent myths about what nutritious food is. So, for instance, we know that any fat that is solid at room temperature is a saturated fat, and it will drive up that bad cholesterol. It will also, depending on the type of oil, might also slightly increase the good cholesterol. But so coconut oil, which is used quite often in the palm kernel oils, which are used quite frequently in Asian cooking, are really quite unhealthy for us. And this particular LDLC, which is a specific kind of the bad cholesterol, has much higher prevalence in the groups that have the highest incidence of heart disease. And this is adjusted for all the other types of things like insurance and smoking status and age. In fact, the American College of Cardiology points out some of the additional risks that Asians have for peripheral artery disease, for diabetes, and for type 2 diabetes, and many other cardiometabolic conditions. So, speaking of diabetes, what you'll find is that the prevalence of diabetes by Asian group also varies. And for Asians and Filipino Americans in particular, it's almost twice the rate of those for Chinese Americans. But Chinese Americans have high rates and it presents earlier. And in fact, in many cases, it is underdiagnosed. So we believe that the rates of diabetes in the Asian community is about twice the rates of those in non-Hispanic whites, especially by subgroup. And this is a recent article published by Dr. Palaniappan, who's one of the two co-founders, along with Dr. Brian Lynn of our Center for Asian Health Research and Education, in one of the American Heart Association journals, talking about the risks of diabetes and stroke, for instance, and why that is, from high intramuscular fat and liver fat to decrease lean mass, and the pancreas not working as well, and also the interaction between genetics and environment. This leads us to a really interesting paradox. In medicine, I'd heard this term TOFI before, and I never understood what that is, but it was thin on the outside and fat on the inside, which is really about the distribution of weight in Asian Americans. So, part of the reason that normal weight Asians have a higher incidence of diabetes and cardiometabolic disorder is because they have higher visceral fat and they have lower muscle mass. So we have to do things in our lives to combat that, from weight training to really watching what we're eating. And the set point for what's considered obese in Asians, surprisingly, is 1.5 BMI less than others. So whereas if you are overweight at a body mass index of 25, if you're non-Hispanic white, it's actually 23.5 if you're Asian. Okay. So I'd mentioned this idea that we have less muscle mass overall, and sarcopenia is a pathologic condition where you're unable to build muscle mass. And, muscle mass is a critical component not only of bone health, but also of fragility and falls. And people who have sarcopenia as they age are about twice as likely to die within the same time year period as others who don't. It's a major fragility marker, and it's tied in with our entire metabolic health. So the American College of Cardiology recommends a very specific approach for Asian Americans that not only drops the BMI cutoff to 23.5, so we're more aware of our risks, but also asks us to personalize things about cholesterol, about nutrition, and really focus in on all of the healthy eight that go into the cardiometabolic risk for heart disease and for strokes. Now, if we begin to look at cancer differences and overall, this is kind of has the prevalence for, it's a heat map of health differences. If you kind of start going down towards the cancer group, what you'll find is that there's a lot of intra-group differences in breast cancer, gastric cancer, liver cancer, certainly lung cancer for people who have specific genetic mutations, and thyroid cancer. And this is just scratching the surface of some of the differences that we're seeing. Nasopharyngeal cancer, for instance, and part of that's driven by viral exposures like to EBV, but part of it's also driven by genetics. Now, for the lung cancer risk, you've probably been aware that Stanford has been holding lung cancer summits, and our own Dr. Brian Lynn had developed non-smoking lung cancer, and it was metastatic at time of diagnosis, and he was fairly asymptomatic, and one of the nicest, healthiest persons that you'll meet. The non-smoking lung cancer epidemic is sweeping Asia for several reasons, and Asian Indian and Chinese women are most at risk. This is thought to be driven by several factors. One is cooking smokes. So although in North America we're not really working over a fire with coal or with other things that are clearly smoky, the fumes just from standard cooking can actually have carcinogens in them. And environmental pollution and other things are driving this epidemic of lung cancer, but there's also genetic mutations. So 80% of the cancers in Chinese American and Asian Indian women with lung cancer are never smokers. And the seeking of care is later. And when people are seeking care, they're less likely to seek palliative care for advanced diseases. So the suffering may be higher. Okay. We talked a little bit about this in terms of Asians are, 4.8 times more likely women to get non-smoking lung cancer for never smokers. Now, if we think about breast cancer risk, I'd mentioned if you kind of look around our community, it seems like more and more Asian women are getting breast cancer, and that's actually true. In fact, API women have the highest rates of breast cancer for women under 50. And when you look at the people who have heritable breast cancer, not the random breast cancers, this is based on the Carolina breast cancer study. What you'll find are the genetic mutations that are present in European Americans versus Asian Americans are actually different. And so you have to screen differently, and families have to talk about these things. Now, this is driven even further by the fact that there's a lot of stigma against breast cancer screening and against things that have to do with reproductive health. So it becomes more important to engage our communities to be able to get people to see their doctor and to be able to get them to engage in constructive dialogue about cancer and cancer risks. So, what you'll find if you look around the world is that there are some mutations that make things more likely to people more likely to get cancers than others. And we find that in Asia, the driver for lung cancer risk is a mutation called EGFR. Whereas if you look at Europe, the KRAS mutation is much more common. And similarly, we can find differences for seizure disorders. And I had already mentioned the genetic breast cancer variation. And this again is just driving home the fact that the cancer expression is important, but screening is also important. So if you are in Asia and you have uh, uh, like esophageal or uh, gastric cancer, you are much less likely to die of it because the screening is so much better. And so people are catching it earlier and they are working towards trying to make sure people are getting in the door. Because in Asia, people are aware of these risks, whereas in America, the communities may not be as engaged. So similarly, sociodemographics, smoking is has a really large variation, especially amongst the Filipino population, which puts people who are Filipino American at risk for all of the smoking-related cancers. And the public health initiatives are unfortunately not tailored towards specific ethnic communities, although I think that's going to be changing in the next few years if we all work together. I want to share a case report that's been widely publicized, but really highlights part of the reason that we need to pay attention to group-specific risks. So this is a gentleman who had gout, which is an inflammatory arthritis based on deposition of uric acid crystals into people's joints. And he wanted to get, because he was having more and more flares, he wanted to get a treatment for it to prevent it from happening, to prevent the flares. So you can see uric acid crystals deposited in his skin and then also in his joint. And he was given a medication that's very commonly used called allopurinol. And he developed a severe cutaneous drug reaction. And the reason for this is because he had a mutation that's very common in Han Dynasty descendants called HLA-B star 5801. So if you have the 5801 uh, HLA type, you are much more likely to get this severe, deadly drug reaction. And it's catastrophic and it can change your life. So if your doctor is unaware that they should be screening for this HLA type before they give you the medication, you could potentially be at very high risk if you have gout, because this is the most commonly prescribed medication to drop your uric acid levels. Similarly, we had the same type of problems with either clotting or bleeding. I had mentioned I'd seen this so often with our Asian patients who have a gain of function mutation if you're Asian Indian and are more likely to bleed. But if you have a loss of function mutation, you are much more likely to clot. So people who are Asian Indian may need less clopidogrel, whereas people who are Chinese or Korean or Japanese might need much more to be able to get the same effect or a different medication. Similarly, the same effect with warfarin, which is another medication for blood clots that you might use after a thrombosis or a deep vein thrombosis or for specific kinds of heart arrhythmias like atrial fibrillation or for statins, for instance. So I don't know how many among you have friends who have something called Asian flush or have this yourself, where if you drink alcohol, you turn red. And that is because there's some people who have an ALDH2 star 2 gene mutation uh, don't metabolize the intermediate form of alcohol called acetaldehyde and turn it into acetone. So you need this a normal ALDH2 1 enzyme to be able to functionally turn this toxic intermediate acetaldehyde to the easily excreted acetate. Okay, so if you don't have that, what happens? If you drink, then your risk of esophageal and stomach cancer can be up to 5 to 10 times higher than those who are not drinking. So with the mutation, your rates go up dramatically. But if you also drink and smoke, and this is combining two different studies. The second study did not involve Asians specifically, but just for illustrative purposes, it can be up to 50 times the risk. So if you do, we know alcohol is not safe at any level, but if you have this mutation, it could be deadly. Okay. So what about other things like sleep, our lifestyle behaviors? And sleep is an amalgamation of so many things from, pain to to anxiety, to retraining our sleep habits. And just a couple years ago, about 2 years ago, the American Heart Association added sleep as a cardiometabolic risk factor as much as exercise, hypertension, or diabetes. Okay. So, what we find is we look at national studies of the prevalence of insufficient sleep. It's actually very high in many Asian American groups, most so in Filipino Americans, and less so in some of the Asian Indians and Chinese, just as an example. But there's a significant variation both with sleep latency, sleep duration, and sleep quality between groups. So, again, another area needed for study and for research. Now, I know it seems like I'm painting a bit of a gloomy picture of Asian health. Again, there's so much variation. My message, what I'm is that we need to be able to look closely at both group level differences and intergroup differences, so that we can begin to have customized, personalized uh, um, care plans for people and for communities that are going to meet everyone's health needs. Now, from a mental health perspective, there's growing mental health concerns. We know that during the pandemic, the visible rise of Asian hate really shone a spotlight on some of those issues. And Asians face different risks because, again, of immigration, acculturation, intergenerational conflicts, and also the stigma about getting help for mental health issues. Now, if you take a look at kind of overall differences, so for instance, while the overall population prevalence of depression and anxiety, the mood disorders, is about one in 1 in 5 for overall Americans. It's about 1 in 3 for Korean American adults. And we'll find that a very small, a much smaller number of Filipino Americans rated their health as excellent compared to, excuse me, a much larger number compared to Chinese Americans and Vietnamese Americans. And these differences in both depression and mental health disease expression and the stigma causes a lot of problems. So, just as an example of the impact of stigma, because cervical cancer and reproductive health is not necessarily something that many Asian communities are comfortable with, and I know I'm generalizing, what we'll find is that the rates of cervical cancer screening driven by intrinsic bias, we believe, and lack of community awareness, drop the rates of screening for Vietnamese women to about 60% compared with almost 90% for all women in California. And these differences in the way we think often drive what we do. So the good news is that suicide rates amongst Asian women, excuse me, amongst Asians, which is the second to the bottom, are about the same as people who it's less than about half, less than half of those who are non-Hispanic white. When you look at age adjustment and also you look at per 100,000, with the highest suicide rates being amongst Native Hawaiian and Alaska Natives. But what we find is once we start looking a little bit closer and we see that suicide is actually the eighth leading cause of death for Asian Americans and the second leading cause of death for Asian Americans between 15 and 43, we also find that US born Asian American women have the highest suicide thoughts compared to the average, which is about 15.4. So this is a slight increase, but still highlights the need for us to be very careful and disaggregate and to be able to look at risk-specific issues. So combining these rates of mental health issues with access to care and seeking care, you'll may not be surprised to see that people who are Asian seek care about half as much or less than half as much for mental health issues as people who are non-Hispanic white. Um, Part of this may be driven by increase in pressures from perceptions of racism. Also, that people don't feel as if when they go to their doctor, that they feel a sense of cultural congruity, and they have people who understand them. Stanford actually has made good inroads in this with the advent of the Smart Clinic, which is a Asian-specific mental health clinic started by the Department of Psychiatry and has multiple faculty, fellows, and students who are all focused on issues around communication of health risks and of culturally appropriate counseling. So some of these barriers to better health care for Asian Americans from include issues surrounding the stigma surrounding mental illness, lack of culturally competent providers. Many of our immigrants have language barriers that preclude them from being able to feel comfortable communicating and accessing care. And people may not even be aware of the available resources, whether it's at Stanford or at other places. Um, so I'm going to and I hope that paints a bit of a picture about some of the issues that are happening within the Asian American health community. And I wanted to talk a little bit about how Stanford, as an institution, is responding to these issues with coordinated efforts to improve Asian health. So you may not know, but there's over 100 Stanford faculty who are focused on issues around Asian health. I mentioned the Smart Clinic, which is our Asian mental health clinic for with also does which does research and training through the Department of Psychiatry. Our center, the Stanford Center for Asian Health Research and Education, actually has a lung cancer moonshot where we're going to try to really fix or address uh, um, non-smoking lung cancer in a very systematic way. We just had our first lung cancer symposium. We have the Asian Liver Center, which is focused on all things Asian liver, from cancer to the ALDH2 issues to hepatitis B and others. For cardiovascular disease, the South Asian Heart Center, run by Raj Dash, has nutrition programs as well as specific counseling around bringing down risk for persons who are South Asian, but also all Asians. And we have multiple studies going on to be able to look at how to think about and learn about and more precisely address cardiometabolic disorders, specifically diabetes. And we just received a generous $5 million grant from a donor to be able to advance this. And then from a genomic standpoint, we're participant in the ARISE study, which is a national study developing a cohort of 10,000 Asians who have generously donated their biosamples to be able to let us start investigating some of the important differences between Asians and all Asians. So the goal of the Center for Asian Health Research and Education is really to improve the health of Asians everywhere. And since Lata and Bryant had started the center in 2017, 2018, we've been very successful in large part because of generous philanthropic funding from the community. We've relaunched the Journal of Asian Health and have had 127 authors in the past couple years, 71,000 citations by Stanford around Asian health work. We've had 50 regional and national presentations from our learners. And we have a program, I'd mentioned the CARE Scholars Program. We've matriculated over 120 students and 22 Team Science Fellows. We have over 100 of our Stanford CARE Scholars alumni who are pursuing careers in health. Many of them have changed their majors to actually work on Asian health and epidemiologic associated um, uh, work. And we have, millions of people who have been viewing the work that we've been doing in our community talks and others like this, hopefully with the increased awareness that we can bring and focus that we can bring to our community. So if you haven't already, please join our mailing list and please start checking out some of our other community talks. We have monthly talks that we're doing. So I mentioned the lung cancer initiative, and we have separately a major gastric cancer initiative um, that led by Juha Wong and by Robert Wong, looking at how we can improve gastric cancer screening. And they have been working with the U.S. Services Preventive Task Force, the CDC, and our state legislature to be able to bring the work of increased gastric cancer risk to and esophageal cancer risk to the larger community and to insurers eventually, so that we can have earlier screening for these things to have the same kind of outcomes that we do in Asia. Um, One of the most exciting things that has happened recently is that we have been invited by the School of Medicine to participate in developing an Asian health curriculum for the entire Stanford School of Medicine, incorporating Asian health research into all 4 years. So I'm going to, in the interest of time, we'll have these slides, of course, available to you. Go over just breeze past some of these issues. And again, please, if you have children or if you have um, family members or friends who have kids who might be interested in participating in our CARE Scholars Program, we invite you to apply. The application cycle opens in fall, and so it closes in early January. We're always looking for great people. It's a year-long virtual program, and we train these young scholars on how to do precision medicine, a large database research around Asian health. So some of the numbers that I shared with you today and some of the graphics that we developed that I had shown actually have been done by our students. And we kind of center on a lot of different competencies. It's more than just producing research. It's really helping focus on them as future leaders and being able to help develop their skill sets to be able to be effective change managers in the things that they want to impact. And again, many of them are incorporating issues for Asian health into their community. And we've had pretty good success in terms of presentations and publications with generous funding from the Chili Pao Foundation. And I'd mentioned the Asian health curriculum. We were invited a year or two ago to participate, and we're going to be we've already started incorporating some Asian health topics into the preclinical curriculum, and we'll start more systematically approaching this. So if this is of interest to anyone on this call, please let us know, because we'd like to do something similar with our larger staff as well, in terms of bringing this content to you in a way that you can use and that's very digestible. So I hope that I've made the case today that as we think about being Asians in America, we have to be cognizant of the individual health risks that we might have that are different than the larger population, while at the same time taking all of the data that we have from large population studies and using it effectively. So together, I know that we can improve Asian health. Stanford's already making significant strides in that direction. And with that, I'll pause and just want to thank you all for inviting me here today. And I hope this was of some use to you.